A very well-known orthopedic surgeon in Udupi as well as in Moodbidri. He is practicing since past 6 years as a consultant trauma and arthroscopy surgeon. His core specialties are complex trauma, arthroscopy and sports medicine. He has completed his MBBS from KMC Mangalore in the year 2010 with the honors, and MS Orthopedics from KS Hegde in the year 2015 as a topper of the batch. He attained additional fellowships in complex trauma, arthroscopy and sports medicine from Chennai. He is a keen academician and has published over 30 research papers in national and international journals. He is a reviver of top national and international journals of orthopedics. He is an associate editor of the British Journal of BMC Surgery, American Journal Medicine and prestigious Indian Journal of Orthopedics. He has presented several research papers in national and international conferences, which include Dr. P. Tejeshwar Rao Gold Medal in the Orthopedic Association Conference in the year 2014 and 15, OSICON Gold Medal paper, etc. He was a recipient of 2 Pablons Gold Medal in 2019 as one of the best reviewer of the world. He was the only Indian researcher who have been highlighted in the website of the British Journal Group of Biomed Central as one of the best researchers in orthopedics in the world. He is very much active in learning and teaching and participates in both offline and online teaching programs and conferences. He is a clinician and surgeon par excellence, which I guess I don't have talk much about that. And as we see the results in the day to day. Ladies and gentlemen, I present you before you renowned Dr. Arjun Ballal. Sir, it's time for you now.
So good evening one and all. I am very thankful first of all to most of you for making this today's program. I would like to begin my program with a vote of thanks. Now you might think, why am I saying vote of thanks? Naan ಎಷ್ಟು ಉಡುಪಿಯವನು ಅಷ್ಟೇ ನಾನು ಮೂಡುಬಿದ್ರೆ ಅವನು 2016 ನಾನು ವೃತ್ತಿ ಶುರು ಮಾಡಿದೆ ಆಳ್ವಾಸ್ ಹಾಸ್ಪಿಟಲಲ್ಲಿ ಮೂಡುಬಿದ್ರೆಯಲ್ಲಿ. And for the past 6 years I have been practicing here, and it has all been possible because of the support that I've found and have received from each and every one, those who are present here. They say that trust is the biggest treasure a doctor has in his life, the trust of the patients. I'm very thankful that you have entrusted the trust the patients have on you to me, and hope I have done justice to the same. You have referred patients to me, you have referred your relatives to me, and sometimes some doctors required my services too. I hope you have benefited out of it and hope I have done justice to that. So I would like to begin with a thank you everybody for this, and I would like to give a small ovation to all of you here for helping me and supporting me. Keyhole joint surgery. So first of all, yes, as you know, I am Dr. Arjun Ballal, orthopedic surgeon with fellowships in complex trauma, arthroscopy and sports medicine. Practice in Udupi and Moodbidri, Mount Rosary and Alwas Hospital in Moodbidri. So times have changed. In the earlier days, it was always a very famous saying that a big surgeon has a big incision. Now, such kind of statements do not hold good. The tables have turned, the clocks have turned, times have rotated. It's now bigger the surgeon, smaller the incision, less soft tissue dissection, better cosmetic appearance, and equally effective surgical result. So what exactly is a keyhole? Keyhole is something like that. As you can see, there's a hole in the lock, and from that you are able to put in the key and you're able to open the world. Sometimes just through the keyhole you can see the whole world. So that is how it is. A small hardly about a 1 centimeter incision in the joint in which we have to operate. We introduce complex instruments into them, and we are able to see everything that is wrong inside that particular joint, and in many cases even repair the damage or the problem that is actually there. So what are the advantages of a small incision? Number 1, lower infection risk. Every time you open a joint, you open a particular area of the body, may it be the organs like the liver or intestine or bone. I can see there are a lot of surgeons here, so they would probably agree with me that every time you open something and you expose it to the outer environment, no matter how sterile your operation theater is, you are exposing it to an environment which contains bacteria, which contains infection, etc. So with keyhole surgery, you can reduce the infection risk to a maximum because the opening is so small and the risk of infection goes down drastically. As far as orthopedics is concerned, bigger incisions, all the muscles, tissues, and whatever we dissect and whatever we expose, they all do not heal primarily. That is, very rarely do they go back to their pre-surgical status or pre-injury status. They end up with scars, they end up with muscle scarring, they end up with stiffness, thereby affecting the day-to-day activity of the patient. When you have something like a keyhole operation where the incision is small, you tend to reduce the soft tissue dissection. You tend to reduce the scarring, hence reducing the complication of joint stiffness. Better cosmetic appearance. We get a lot of young patients, especially ladies, those who come to us with certain fractures, certain injuries, who usually tell us that, Alag nanla madmeataji, so please minimize the scar. Please reduce the appearance of the scar on the skin so as that, we could proceed with our lives in a better way. So keyhole surgery has revolutionized that. It has reduced the risk of having big scars and poor cosmetic appearances. Again, as I told last time, less soft tissue injury. Reduction in opening the muscle, opening the soft tissue elevation, periosteal elevation, etc. reduces soft tissue injury in the patient. Once soft tissue injury goes down, all the above complications are reduced. Hence, reduced soft tissue injury is a major advantage of a small incision. Very less postoperative pain. The whole human body, as we know, is supplied by lots of nerves. So when you touch and fiddle with nerves of the periosteum or the muscle or whatever it is, you tend to produce postoperative pain. The patient is burdened with large amount of analgesics, injections, etc. So that can be reduced by means of keyhole surgery because it reduces the exposure as well as reduces the soft tissue dissection in this patient. Early recovery, again, on the soft tissue point of view, the recovery is faster because the muscles and the tendons and the ligaments which basically support the bone are untouched. And of course, access to deeper compartments. Deeper compartments is especially in the knee joint when you have an infection, or in a shoulder joint, or a deep injury in the hip joint, where instead of opening the whole joint and exposing the compartment, affecting the blood supply to the bone, use of a small scope into the deep compartments will be just like introducing a submarine into the water. So that will go and that will tell us what is wrong, and if required, you can open the joint. Now this is what can we do keyhole surgery in trauma. This is not exactly keyhole. Something called as a MIPO or the MIPPO. MIPO is minimally invasive plate osteosynthesis. MIPPO is percutaneous plate osteosynthesis. So what exactly it is? See, as you see in the central picture, the patient has a fracture in this area. So we put an incision way down where the fracture is not there and push the plate right from here top. So you can get a plate fixed like that where the fracture is untouched or the blood supply to the fracture is untouched. So the blood supply is perfectly normal in these particular patients. Hence there is a faster recovery of the fracture in these particular patients. Hence it's called as a minimally invasive plate osteosynthesis. Again, not exactly a keyhole procedure, but a minimally invasive procedure. Why I read this slide is just to tell in traumatic cases, this is one new advance that can be done in these particular patients. We can do it in the femur, as you can see here, or we can do it in humerus fractures and also in tibia fractures. Now this is my publication on MIPPO, where I used 20 patients. For them, I had done a distal tibia plating using the MIPPO technique. I had published it about 5 years back. It was also visible in PubMed. I had presented this in the national conference that Sukesh sir just told about. Yeah, now coming to the core topic, let's not discuss about MIPPO because MIPPO is again a separate topic to be discussed. Let's come down to arthroscopy. What exactly is arthroscopy? It's primarily a minimally invasive procedure where you visualize the interior of a joint using an arthroscope to diagnose various conditions and in many cases treat the various conditions in these particular patients. So you can remove the damaged tissue, clean the pus or the infection that is there, debride, and maybe even replace the affected area. So this is how it looks like. This is the shoulder joint, where we have introduced a scope right from behind, where we introduce the stitches from here, and we can repair whatever is wrong inside. Can you see, this is the knife. So using a 11 number blade, we just do a stab incision, a very small incision, something that we call a straw tip incision to these patients to perform the operation. This is how it looks like. An arthroscopic shoulder will have just 2 stab incisions, 2 or maximum 3 stab incisions with just 1 stitch, whereas an open procedure in the same hand will have such a big scar. So what are the instruments we use for performing this procedure? That is called as the telescope, for which we connect a light source. You see this line, this is the light source. This is what helps us and provides us the light inside the joint while we are operating. That is where the camera goes. So the camera is connected to the telescope, and this instrument is introduced into the joint. This is held by the surgeon and is manipulated, and you see the things on the screen while it is connected. This is called a trocar. Now from here we can collect fluids here on this side and a suction here from this side. So we can keep pumping fluid into the joint, which thereby inflates the joint and helps us to perform the operation. These blue color things that you can see here, these are called cannulas. So these cannulas are primarily used in order for us to help us to introduce surgical instruments inside into the joint. And then of course, you've got a wide variety of shoulder and knee joint instruments, such as ACL jigs, such as suture passers, such as ACL punch, meniscus punch, etc., which aid us in performing the operation as a whole. And of course, 0.9% normal saline, that is basically to inflate the joint. Unlike laparoscopy surgeries where you inflate it with air, we have to inflate it with saline. What are the most common joints we perform arthroscopy on? The most common joint is the knee. Knee is where exactly maximum arthroscopy surgeries are performed. I'm sure most of you would have had patients who would come and tell you that they have undergone arthroscopy somewhere down the line. They would have undergone an ACL reconstruction. That's the most common performed ACL reconstruction, the most commonly performed arthroscopy surgery. Second is the shoulder. Shoulder, especially rotator cuff tears, or if you have to do some acromioplasties, frozen shoulder releases, especially in diabetic patients, are very effective with arthroscopy surgery because it's minimally invasive, and again, the scarring that is there can be corrected. Then it's the elbow, then it is the ankle. Ankle is still in the very nascent stage. Very few centers those who perform ankle arthroscopy. Hip is not very far now. Hip is also being conquered. One big problem with the hip is the blood supply of the neck and head of the femur primarily lies in the capsule. So if you have to perform an operation to diagnose a particular pathology in the hip, not like replacement or anything, if you diagnose a particular pathology inside the hip joint, you would have to cut down the capsule, which would cut off the blood supply and lead to the most disastrous complication of avascular necrosis. So using a minimally keyhole procedure where you just introduce the scope inside with a small puncture incision to the capsule will not affect the blood supply much. Hence, hip arthroscopy is also picking up. And very, very rarely, wrist and hand arthroscopy, especially in carpal tunnel releases or any small joint pathologies, this could be the future. So what are the indications of arthroscopy? Why would somebody want to do arthroscopy? Why would you require an arthroscopy? Joint inspection. If you have got a pathology inside a joint which you are not sure as to what it is, instead of doing a big open incision and thereby diagnosing something which is very bad, it's better to go via arthroscopy because it's minimally invasive. And once you are sure and you feel like it requires an open procedure, you can proceed with an open procedure. Number 2, ligament reconstructions. Again, as I said, this is the most common procedure done. Cruciate ligament reconstructions. Anterior and posterior cruciate ligament, especially anterior cruciate ligament reconstructions. We perform considerable amount of them in Moodbidri also. Rotator cuff repairs in shoulders, especially in patients, young patients, those who have got an active young patient with a rotator cuff tear, arthroscopic rotator cuff repairs are quite effective. Synovectomy. Synovectomy is again more in the pediatric age group, especially in patients those who have got hip and knee synovitis, post-infection. Again, risk of scarring, risk of joint stiffness, all that can be minimized by trying to do an arthroscopic procedure. Joint debridements. As I said, access to deeper compartments is easier with arthroscopy. Hence, joint debridements could be useful by using an arthroscopy procedure. Articular assessment before intra-articular fracture fixation. See, especially in a joint like the knee, where you have, especially as we know, there is a tibia down and the femur up. The tibia gets a fracture. Tibia is a little notorious because whenever you get a tibia fracture, the articular surface or the joint surface of the tibia dips down. So whenever we try to fix the tibia, you have to elevate the bone using an instrument called as a punch and then stabilize it with a plate. So when you have, you really don't know how much you have elevated, whether your elevation is right, whether elevation is wrong, because if you have not elevated enough, the patient can have joint arthritis later. So there is requirement that you have a proper joint elevation. But then the only way to see it is to open the joint. Instead of that, if you can use an arthroscope, visualize the joint as you're elevating. With a minimal incision, you'll probably be able to see how much you have elevated, whether your elevation is right, is enough, and you can plan, especially in young patients. Old patients with arthritis, anyway, it won't matter. Removal of foreign bodies. We had a patient who had a wound on his skin, and neighbor told him that because of the wound, you can put some tulsi leaves on that and that would heal. So they did that. They came to us after a year with repeated knee infections. And he was a 15-year-old boy. So then boss decided that this is not something that we have to open, something we have to do. And for Rashmi madam, yes, boss is Dr. Siddharth Shetty. So then we pushed in the scope inside. We visualized there was a tulsi leaf inside which was stuck that was repeatedly causing infection for almost quite considerable amount of time. He was in a lot of pain, had taken small micro debridements here and there. Then after we removed that, he tended to recover. So removal of foreign bodies with minimal cosmetic scarring is a very effective way of doing this. Especially, again, these are perspective of young patients. Some joint, now this mosaic plasty and autologous cartilage implantation, this is a newer advent. Whenever a patient has got early onset arthritis, which is quite common nowadays, we have patients coming in their 30s or probably early 40s with considerable amount of arthritis. They are not candidates who can be pushed into the theater for a joint replacement because it's too early. So doing something like this, like a mosaic plasty or an autologous cartilage implantation, what does it mean? We tend to harvest the cartilage from one particular site of the body, which we try to grow it on a stem cell lab, and by using minimally invasive procedures, we redesign this thing that is designed, the graft that is designed, which is kept there and stitched to the native cartilage. So that is called as autologous cartilage implantation. Shema has recently started a stem cell lab where they have this tissue banks for performing these procedures. Arthroscopy associated arthrolysis, yes, because of open surgeries and because of repeated infections, there will be large amount of joint stiffness and joint scarring and joint destruction. So doing something like a arthroscopy associated debridement of that particular area could reduce the risk of further stiffness. Capsular release in frozen shoulder, very commonly performed, although not in Bangalore areas. We have seen it very commonly in Chennai, where especially in a patient with diabetes who has a frozen shoulder, usually is noted to have large amount of fluid collection, scarring and stiffness of the shoulder because of the capsular thickening and because of devoidance of blood supply. So with an arthroscopy procedure, we tend to clean up all the dirty thing that is there. We clean up all the scar tissue, all the dead tissue, and also manipulate the shoulder at the same time to have good surgical release. So I'll talk about two operations in very short way. One is a commonly performed operation. The second one is a very rare operation. I hope you can follow it up with me. See, this is how it is performed. As I said, see, the surgeon is pushing the scope inside into the knee joint and is seeing it on the screen. So this is how we perform arthroscopy in these patients. So this is ACL reconstruction that I'm going to tell you. What is done, how it is done, what it is, and how it is diagnosed, etc. So that most of you can perform it in your clinics. The diagnosis in your clinics, and you will know how to go about whenever a patient comes with an ACL injury. So That is the ACL. You follow this yellow circle here. See, that is the knee joint. As we know, this is the femur, this is the tibia. Then you have got all the ligament structures here. You have got this white thing. This is called as the meniscus. Meniscus is the main stabilizer and force transducer in the knee. The femur and the tibia never form a perfect fit. So the forces what come from the femur are not equally distributed in the tibia. That is where you have got meniscus or the cushions. These are responsible so that the biomechanics of the knee is maintained. As soon as patients start getting old, the meniscus starts drying out. It loses its elasticity, loses its strength, and starts going into tears and all these problems. So that is where the naked distal femur meets the naked distal tibia, bone on bone. That's when the arthritis starts. Until then, usually that's not a problem. But now because of junk food and all that, people are gaining a lot of weight. And in very young ages, we can see patients going into arthritis. So that is the ACL. ACL is also called the anterior cruciate ligament. What is the job of this cruciate ligament? Is to assure that this is the femur and tibia, as I told you. The tibia does not translate anteriorly. It holds the tibia in its place in attachment to the femur. Similarly, there is a ligament on the back called the posterior cruciate ligament. That prevents the tibia from going posteriorly or translating posteriorly. So this injury is very common, especially in the sports department of all of us, because they are involved in kabaddi and football and all these things. They end up with very common ACL ruptures. So this is the cross section of that. You can see now these C's here that you can see, they look like cashew nuts. These are called as menisci or the meniscus. And this big structure here, can you see this? This is the patella. This structure is the posterior cruciate ligament. And this thing here, this white thing here, that is the anterior cruciate ligament. Just wanted to show you the locations of each ligament. Now, you can have a partial tear or a complete tear. Complete tears are more common than partial tears. Then there is something called avulsion. Avulsion is when the anterior cruciate ligament pulls out a piece of bone along with it. It's not exactly a tear because the ligament is intact, but it will pull the bone out like a sleeve like that, and the bone also comes out. Hence, it's an avulsion injury. That also again is not very common. Complete tears are more common in these patients. So what is the main complaint they will tell? They will tell instability. ನನಗೆ ಮೆಟ್ಲು ಮೇಲೆ ಕೆಳಗೆ ಹೋಗ್ಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ. Especially they will tell ಮೆಟ್ಲಿಂದ ಕೆಳಗಿಳಿಯುವಾಗ ಕಾಲು ಜಾರಿದಾಗೆ ಆಗ್ತದೆ. I'm unable to stabilize my knee, especially when I'm getting down from the stairs. I'm unable to sit on the ground. Pain is not exactly a complaint of ACL tear. They don't complain of pain very commonly. They complain of instability. Pain comes when the meniscus is also involved. When a meniscus and the cushion is affected, there is pain. But very rarely in ACL there is pain. More is instability. So the most commonly performed test that anybody can do, everybody can do in their clinics whenever a patient comes is the Latchman test. Latchman test is perfectly safe because some of the tests, if you perform, it might affect the injury further. But Latchman test is the safest test. How do you do it? Have the patient completely supine on the bed. Flex the knee up to 30 degrees like that. Hold the femur with your left hand, the thigh with your left hand, and hold the tibia with your right hand, like that. And you just pull the tibia forward. As I said, ACL is responsible for preventing the translation of tibia. So in case the tibia starts coming aram se in your hand, that means probably the ACL is torn. If you are not sure as to whether it is a tear or not, do the same test on the uninjured knee, on the normal knee, and see how much it comes forward. If that is coming up to, let's say, hardly about 1 millimeter, this will come up to 3 to 4 millimeters. That means, yes, ACL is probably injured in this patient. So very common and a very easy test. So whenever you have a patient with knee injury, instability, difficulty in walking, climbing up and down the stairs, especially this test will help you before you push them into an MRI machine. MRI is definitely the main thing. Yeah. How to read an MRI? Just a basic crash course. See, this is the sagittal view of the injured knee. When you have a normal ACL, you just follow the pointer. You see the black mark here? This black question mark. Can you see? I'll remove the pointer. This black question mark is intact. That is the ACL. Whenever this black question mark is not visible, that means the ACL is torn. It's a complete tear. So whenever you get an MRI, patient usually comes with an MRI sometimes after going to some 10 places, you just put on the screen. Because what we have to remember is, so many times radiologists also miss ACL tears. Or they will diagnose ACL tears, the patient might not have an ACL tear. So you have a doubt, patient says, yes, ACL tear is there in the report, kindly do the Latchman test. A clinician and a clinical diagnosis is more important than a radiological diagnosis, because some knees have got so many artifacts that you might misdiagnose that it is something else. So before that, clinical evaluation is important. So what do? We proceed with the operation. This is how it is. Push the instruments inside, the scope, the camera, and the place where we push in the fluids here. And this is called the probe. Probe is basically we use it in order to see if all the ligaments are intact or not intact. This is an arthroscopic image as to how a torn ACL comes. Now can you see this? This PCL, can you see? This is posterior cruciate ligament. See how nice and how straight and how connected it is. Whereas the ACL is here. It's supposed to come like that, but it is torn, it's in shreds, it's completely destroyed. So this is a complete tear of an ACL. This is how it looks in the scopy. So what do? ACL is a ligament which does not have its own blood supply. So repairing an ACL is of no use. It will not recover. You have to reconstruct the ACL. That means you'll have to harvest something from somewhere, refashion it, redesign it, and put it in the place of the native ACL. So the new ligament what you have prepared is the new ACL in these particular knees. So we commonly use the semitendinosus. That is, semitendinosus is from here. There's an area called as the pes anserinus, which is close to the tibial tuberosity. So we put an incision there. See, can you see this? This is the semitendinosus being elevated by means of an instrument, and this is how the whole semitendinosus comes out. That's how we remove semitendinosus out using something called as a tendon stripper. There's a big instrument like that. We push around the semitendinosus and harvest it out from the same knee. So this is how the tendon is prepared. So this will be the new ACL in the patient. The semitendinosus tendon is removed and it is stitched like that and prepared like that and made into 4 loops. So it's called as a quadrupled graft. Quadruple makes it more stronger. And then you have to drill holes into the femur and tibia. Once you are having the graft, it is, how do you insert it? You insert it into the holes. So you drill one hole into the femur and one hole into the tibia. So, and then you push the graft all the way from the tibia into the femur, into the place where there was the primary ACL. So the first ACL iddalli, again you push this graft and then you have to fix the graft. How do you fix the graft? You fix it, see that is you see this white thing, this is the new ACL. There is a tibial tunnel here and there is a femoral tunnel here. And this is the new reconstructed ACL. So you have to fix it by means of a one screw down and one screw up, or one screw down and something that we call an endo button. Endo button is basically a titanium button around which stitches go and you fix it by means of a stitch. So this is an endo button and a screw fixation. So you can see this comparison post-operative inside the OT itself, but after the surgery is over, this is how it was, all torn and in shreds. Now you see this nice graft which has come into its place to take up the place of the new ACL. So that will start functioning as a new ACL in recovery of this particular patient. This is a post-op X-ray. Can you see that? That is a screw, the yellow circle, and this blue circle here is the endo button. Endo button, what I told you to stabilize the graft. Surgery is just 40% in these patients. 60% is rehabilitation. A good surgery with no rehabilitation will have a stiff knee for the patient. It's very, very important that you rehabilitate. You make the patient follow up. You teach him the exercises. I usually have a graduated protocol where for every 2 to 3 weeks the patient keeps changing exercises so as to have his full function of the knee in a span of at least up to about 3 to 4 months. And if he's a sports person, he can get back to sports in a span of about 9 months to 1 year, depending on the sports. So rehabilitation forms the most important part of ACL surgery. Surgery is again just 40%, what you just saw. This forms the core of recovery. So many times patients after surgery do not follow up and end up with joint stiffness, which is usually a problem. Second one is a very rare surgery. Probably up till now 5 years we have performed this only one of such surgery here. There is something that, and even the condition is also very rare, so it's not very commonly performed. This is called as the Stieda process excision. Stieda process is something that we call as an os trigonum, which is presents like a beak on the posterior aspect of the talus bone. Now this is the talus bone of the ankle, and you see that beak around the red circle here. That is called as the Stieda process. Now this X-ray is actually of an Irish doctor, anesthesiologist, who presented to us with severe ankle pain, unable to walk, and lot of stiffness due to pain and no mobilization. So when he presented it to us, we did that X-ray and we found that. Then we proceeded with an MRI to know the situation of the soft tissue underneath, and you can see MRI also beautifully shows this extra beak what is there. So again, minimally invasive as he is Irish. So you can see that red arrow over here. This is inside. Once you put the scope inside, you see this red arrow. This white structure here is the Stieda process. Okay? That is called as the Stieda process. So what we did, we introduced something called an osteotome, which is like a chisel with a small micro incision again, and we chopped the whole thing off by means of this. Then we have got one more instrument called the shaver, which primarily cleans up all the debris, all the tissue what is dead and tissue what is injured because of this Stieda process. Once that is done, this is the clear space after the Stieda process is excised. And you can see the red circle here, the Stieda process is removed. Now doing an open procedure is also an option in these patients, but the thing about talus is a bone, again, it's just like the neck of the femur, head of the femur. It's got very limited blood supply. We try to fiddle with the talus, it can also go into avascular necrosis. An arthroscopy procedure definitely added an advantage and also bring about good cosmetic clearance in him. And with good rehabilitation protocol, he recovered 100%. So this, I had published the same in Journal of Arthroscopy and Joint Surgery, and this was the OSSCon gold medal paper what Sukesh sir spoke about. This also was published in the JAJS. So, coming to the last couple of slides, what is the take-home message? Always smaller the better. That is, the more smaller the fish, more bigger you can feel the aquarium. So bigger the fish, the aquarium size goes down. So introducing small instruments, doing small procedures definitely has added an advantage. But what you should understand, the final decision is of the surgeon operating. He decides what is right for the patient. Just because arthroscopy is an option does not mean that arthroscopy is the only option. A particular patient who might not be fit for arthroscopy definitely would require an open procedure. These are the advantages of performing arthroscopy is what I'm presenting to you. So this, I hope how many of you know this person, I don't know. He's Dr. Sir John Shanley. He is the pioneer of joint replacement, somebody who made joint replacement possible today. The father of joint replacement surgery in the world, British orthopedic surgeon. And many people confused him to be an engineer and not a doctor because his methods, his techniques of performing operation was more like an engineer, because he is the person who understood biomechanics so well that he was able to design operations to have the best outcome. He has so many inventions to his name, like Shanley's compression arthrodesis, Shanley's space suits, Shanley's joint replacement implants, etc., etc. I can go on. He can also be termed as the Edison of orthopedics. In simple words, what he said once was that orthopedics is nothing but the marriage between mechanics and biology. You should understand the biomechanics before understanding biology of a particular joint. Before performing the operation, a beautiful post-op X-ray, a beautiful intra-op C-arm image might deceive you to say the patient will do well. The patient might not do well. Your operation might be flawed. So the most important part is the follow-up, is till the end how much responsibility you can take up with following up with the patient. Hence understanding mechanics for a particular fracture is more important than fixing the fracture, or rather understanding mechanics before fixing the fracture is very important so as to even fix the fracture here. So ladies and gentlemen, thank you very much for your kind attention.